My name is Stephanie Ramsey. I am the nurse educator for the Army Central Simulation Committee and the Anderson Simulation Center based out of Joint Base Lewis McChord in Washington State. This brief will outline the benefits of using medical simulation for interprofessional education in relation to a mock resuscitation training program at Rule 4 military medical facilities with the goal of patient and staff safety, ultimately leading to increased quality patient care and outcomes. I have no disclosures, financial or otherwise, and the views that are expressed in this presentation are that of the author and do not reflect the views of the Defense Health Agency or the Department of Defense. In 2021, the Joint Commission published the R3 report. The report outlines the updated standards on resuscitative services that are provided at all Joint Commission accredited hospitals, from critical access hospitals to level 1 trauma centers. Patient Care Standard 02-01.11 states that resuscitation services must be available throughout the hospital. The rationale for this patient safety standard is that providing effective and high-quality resuscitation efforts is critical for patient survival. The requirement states that hospitals provide resuscitation education and training for all staff involved in patient care areas where resuscitation events may occur. The revised standard on resuscitation care further addresses several interlinked factors that have been cited as critical to resuscitation performance, namely the quality of hospital personnel training, adherence to evidence-based protocols, collection of data, and the implementation of internal quality control and case review mechanisms. The focus of this presentation will be on medical simulation to establish safe, effective education and training of interdisciplinary healthcare teams. The Joint Commission focuses on resuscitation efforts due to the fact that resuscitative efforts are high acuity, low occurrence events that account for 79 of sentinel events, near misses, adverse events affecting patient outcomes and length of hospital stay. Communication is the #1 skill that directly influences the quality of care a patient receives. Patient care is further influenced by the strength of the various backgrounds of each person on the team and the staff's perception of the team's communication and teamwork. Both contribute to the development of a shared mental model among the healthcare team. Per the R3 report, the hospital must provide education and training to all staff members who would be involved in providing resuscitative services. To do this, the hospital determines which staff members must complete this education and training based on their job responsibilities and hospital's policies and procedures. The education and training is provided at the following intervals: at initial orientation, periodic basis, such as determined by the hospital, and when staff responsibilities change. Education and training topics that may be covered are resuscitation procedures or protocols, the use of cardiopulmonary resuscitative technique, descriptive devices or equipment, and the roles and responsibilities of each team member during a resuscitation event. Per the R3 report, the hospital must provide education and training to staff involved in not only should education and training be provided on the following intervals of orientation on a periodic basis and when staff responsibilities change, but also on an ad hoc basis to prevent team skill degradation. For the military, it is also important to conduct resuscitation and trauma training prior to deployment, especially when medical teams from different branches of the military are coming together. This assists, again, with establishing a shared mental model with the team, leading to high-quality patient outcomes. So, how do you establish a mock code resuscitation program and make it sustainable? The first order of business is to obtain leadership support. Then perform a needs assessment to see where the education gaps and needs are amongst the staff. This is best done by consulting the staff that is directly involved in resuscitation efforts and actually makes the wheels turn. Then do a crawl, walk, run. The crawl phase should include allowing the staff to become familiar with the equipment used in the resuscitation setting, such as crash cart, medications, monitors. The walk phase should be the reviewing of a resuscitation scenario so the staff can become familiar with the possible cases that they may encounter and the various roles that each team member has. The run phase involves letting the staff know that at some point in the next X time frame, a mock resuscitation code will be called and that they are all expected to respond to the training event as if it is a real-time event. This concludes my presentation. Here are my references, and thank you so much.